So welcome to the panel. Three of them you've seen this morning and in other events. We'll be talking to them later. The one person you haven't seen in plenary forum is Slee on my right, from NHS England, Assistant Chief Clinical Information Officer, brackets pharmacy, I think is the correct. Medicines. You're right. I suppose you would be. Apologies, Anne, but and I think it's appropriate then I start with you. So if you could say a little bit more about yourself and the job you're doing, and perhaps comments on some of the things you've heard during this conference.
Okay, so I work with Simon Eccles. I'm one of his Associate Chief Information Officers. My background is pharmacy, particularly secondary care pharmacy. So like Iain, I come from a Director of Pharmacy role and have worked in the health informatics arena for quite a while. The interest I had started a good 30 years ago now when I worked at Wirral and we introduced electronic prescribing across the Trust, one of the first organisations to do so. So it goes back a great number of years. And more recently, I've been working nationally and also working to set up the faculty. So quite a broad and diverse career so far.
Very good. And at national level, and I know you know a good deal about GS1. In fact, you're a member of the Healthcare Advisory Board that I chair. Any views from that level on what GS1 and everything goes with it can contribute from your observations so far?
We've just done quite a big piece of work with GS1 supporting us in terms of what we were doing. One of the things that we're seeing moving forward, and Iain's beautifully described it this morning in terms of closed-loop medicines work, is the need to create a data pool which links the Dictionary of Medicines and Devices, which is the standard we're using within the NHS for medicines, and we come back full circle to standards and open standards, as Richard identified. But what we needed to do is create the data pool to link the GS1 codes, the GTINs, which sit on medicines, to the DM&D standard. So we've just completed a very big piece of collaborative work between NHS England, NHS Digital, the BSA, with support from GS1 to map all of the AMPPs, which are the actual medicinal products, so the packs of medicines that you will use, to that standard, so that we now have over 94% coverage, which will help us to move forward in terms of the adoption of the technologies that have been described by Iain today.
Right. Thanks, Anne. Iain, while we're talking about medicines, if we can follow up a little bit from your presentation, and it's a theme that will go through other questions and has already been talked about a little bit, is impressive results we see from you down in Cornwall. But my observation is it's not really been having an impact elsewhere in England or the UK. Is that right? And is there something that we're missing?
I think that is right, but we're in some ways in quite a fortunate position as well, in that certainly within the pharmacy world, we are, from a stock control position, we use quite a few number of systems. So actually, once one system becomes compliant, actually half the hospitals in the country will suddenly become compliant with GS1. Right. So it's been very painful to get to the stage that we're at now, but we do at least have those processes, those systems in test, which are GS1 compliant. We're hoping to have those rolled out in the next sort of 6 months. And as I say, that will then leapfrog us from being at a really bad position now to suddenly a seismic change. So it's been painful, and it is painful. Things like the database are going to be really helpful for us to have that data pool there. But so I'm optimistic.
Great. Okay. And I know there are colleagues out there from the medicines pharmacy, if at some stage during this session you want to add anything on the medicines side, please put your hand up, and I'll bring you in at that time. If I can widen then into the information world more widely, I've been around a long time, you can tell that, and been through many organisations, many structures, and information was never, or IT is probably more it was called then, was never part of many senior teams. That has suddenly, my impression, has burst into life. I think my first GS1 conference, probably 4 or 5 years ago, and I've not checked, but I bet there wasn't one CCIO or with that title, or CIO with that title there. So in a very short time, it's really prominent. Is that a fair comment? And why has it happened? And what are you going to do as a result of getting that promise? Perhaps, Richard, I could ask you to...
You're right, it is new as a senior exec role. It's something that Hancock has come out and said that trusts should do. I think IT directors, CIOs across the NHS are somewhat split over whether it's the right thing to do. Personally, my own view, it is the right thing to do, because if you're not at the table, then you can't be involved in the transformation decision making. Yeah. For me, the CIO role is different to an IT director though. The CIO role has to be about transformation and the strategy to achieve transformation, not tin and wires and Wi-Fi. We talk about an exec role on an exec corridor in an NHS organisation responsible for IT needs to be able to do 3 things that begin with P: passwords, PowerPoint, and the projector. And we have to move away from that. It has to be transformation strategy, not passwords, PowerPoint, and projectors.
Yeah. That's a powerful point you make there. Graham.
Yes, interesting. Echo many of Richard's comments there. I'll just go back to my time in industry. And about 20 years ago, industry said that if you want to really transform your business, it's about efficiency, effectiveness, then competitive edge. And the way that organisations did that back then was to have a technology specialist in the conversation with the business leaders. I think the NHS is now just thinking about that in many parts. So I think, it's back to Richard's picture of the Leeds board. If you get into the conversation when it's too late, you do become an afterthought. So being there at the beginning of the conversation, and you can then influence the solution to the problem. And I think that's really important for the future.
Okay. I'm very aware when you come to conferences like this, that you see the leaders, you see the people who are doing things. That's why you're here, that's why you've been invited. And there's a great deal now, great deal of excitement, a lot to do. But are we misleading ourselves? Have we got generally out there the people who want to deliver this agenda? I don't know that. It'd be interesting to have your observations about whether we're ready.
I think there's become an acceptance that if we're not, the healthcare system will fail. I think that's the difference now, that this is no longer a let's try because it's nice or cool or funky or different. It's if we don't try, then we won't succeed. The NHS England guidance ahead of winter 17-18 was the first time in 20 years that IT was mentioned as a possible helpful solution to winter pressures. Now, for me, that was a hallelujah moment, because at last the centre, not IT at the centre, but the centre recognised that without technology to move information and move the system forward, we're going to fail. Yeah. And I think every chief exec has been given warning by Hancock and others that you need to consider and do something about this time. This isn't a nice to have. Doesn't always mean the money flows, doesn't always mean the priority works, but it has been seen as the answer to many of the issues.
I think we're seeing a groundswell of frustration as well, coming up from people working in frontline services. They're used to using technology in private life.
Yeah.
You know, we've got more technology at our fingertips to support our shopping than we do to actually support the job that we deliver. And I think that groundswell is actually starting to have quite a marked change as well.
Yes.
You know, we're seeing it in a lot of different ways.
Right. My impression is that clinicians really want to get involved.
Yeah.
I noticed it many years ago in a previous life that GPs then were the people that were really pushing IT. I'm talking the 90s. Now, I think they were bored of being GPs and the information. And I said in a forum yesterday that I chaired in Bedfordshire the primary care information group. And the main GP was Mary Hawkins, who was Stephen Hawkins' sister. And she was intellectually at that level. And she was a great advocate, although it taught me the skill of being able to chair meetings for 3 hours without understanding a word of what was being talked about. But clinicians, again, your observation, really do want to get involved. They enjoy the intellectual stimulation, is that right? As well as most understanding the benefits that it can now bring. Graham?
I think what you've described there, Duncan, is absolutely right. Richard mentioned, you know, having a paragraph in your business strategy. Well, actually, it needs to be woven throughout the entire strategy. The long-term plan gives us a blueprint that many organisations can then follow. But this isn't about doing the same things better. This is about doing better things, and technology allows us to do that. If we want to attract the brightest and the best into the health and care system, we can't be using chalk and slate. We've got to keep up with everybody else.
Right. Whilst I've got you engaged, Graham, yesterday I chaired the workshop on integrated care systems, and I have to say I was blown away, and I mean that, with what was going on in the northeast. We heard from you and Alan Foster. Can you say a little bit more about that? Because I'm picking up from yesterday Matthew's Swindell's, and integration is the way forward. Where does this agenda come into that?
Well, this is part of the jigsaw.
Yep.
What we're trying to do is build from the bottom up as well as top down. I think I've got a bit of transformation envy from what Richard was saying, and also his PowerPoint slides as well, which I will steal mostly. I think that the North East is the biggest integrated care system in the country. Deliberately, there's a natural alignment with what we do in there, and Alan will talk in far more detail than I can. But we've had success for many years. I had a role in a former life as the CIO for the North East Health Authority. Remember health authorities? It's a bit like the 1970s lava lamp. Things get warmed up, it fragments, and then the NHS cools down. It's a big blob again. So I think we're cooling down again at the moment. But it's about setting a vision. It's about describing where we need to get to collectively. And it's not the usual suspects. I was on a tour of the stadia of the North Eastern Cumbria over the last couple of months, along with our medical directors. And we weren't talking to the chief nurses, the medical directors. We were talking to the guys on the shop floor that know how to fix some of these problems. And they described the things that we need to do. And it wasn't all about shiny tech. It was about getting the basics right. You know, if you've got to have 400 mouse clicks to get into a system, if you've got 37 systems with different credentials, people won't use that. So the technology will transform, but get the basics right, then start to incrementally build the case for change. People, process, and technology aligned to a common vision and purpose. That's the future.
Can you tell us the Steve Cram story briefly? Because that brought it home to me, what a lot of this is about.
So one of the flagship programs in the North East of North Cumbria is our LICRA program, and we've called it affectionately the Great North Care Record. And as many of you will be aware, one of the big brands in the North is the Great North Run. So I was privileged to know Steve through a personal relationship, and I asked Steve if he would consider being the patron for the Great North Care Record. Steve opened up our second digital summit about 2 weeks ago, and he started by talking about a very personal story of the health and care service that he experienced through his mother and father. And in essence, to cut a long story short, at every point of interaction, he had to repeat the same thing: name, age, previous medical history. And a lot of his father's medical history, and I won't go into the detail, had been lost. So that longitudinal history was no longer around. So Steve had to keep repeating this to make sure that the best service could be provided. What Steve was, he was the health information exchange for his father. He was the glue that joined those points of information together that could be directed at a clinician. What we are doing is replacing Steve with some technology, so it's there every time when you need it to make the right decision.
Yeah, great analogy. As we heard, major decision of awarding GS1 the contract from NHS Digital, and CIOs are going to be made responsible for implementation. Will that matter? Will it come as a surprise to CIOs? Will it?
Yeah, it will come as a surprise to CIOs.
Yeah,
I think that's always interesting when it becomes a NHS Digital statement and nobody's talked to the CIOs until it goes out on a slide from Glenn. Yeah. But I'm sure the CIOs here tweeted it and we'll all know by next week. But it's not a problem that it's a responsibility, but we're very good as an NHS at creating responsibilities and targets that are actually called wishes and business cases because there's no funding to follow them up. Yeah. And GS1 is a standard that the CIO is responsible for to the board to deliver is great. And it's a fantastic start. But show us the money to do it as well.
I think it's more than that, though, isn't it? I think it comes back to everything that's run through the 2 days. It's not about the standard. It's about using that as a way of supporting transformation. Absolutely, and it should be the other way around. Yeah. And that's what we've forgotten in identifying that as the standard. And it also comes back to it's not the CIO's responsibility, it's a shared responsibility.
It's good to have it as a person at the board is responsible for the delivery of it, but I doubt a CIO will be sacked for not delivering the standard to an NHS organisation in 5 years. And the CIO can't make the systems or the clinicians use the GS1 standard. It has to be about transformation and benefit, which is our job anyway.
Great.
A final question then from me for each of you. What should GS1 be doing now to help you move the agenda forward, help CIOs who probably don't know anything about GS1 in some cases? So any lessons, any instructions for Glenn and his team?
I think it comes back to Terence's point earlier about how we support spread. And I think it has to be around dissemination. That's the key bit. It's the evidence and the dissemination. And I think that's a marketing and a communication exercise, which GS1 can absolutely help with in terms of making sure we get those messages out and we share them as widely as possible.
Great.
There's that promote. GDEs have the responsibility to create blueprints. Let's get the original organisations and those that have implemented GS1 to blueprint how they've done it and give it freely to every NHS organisation so that nobody has to learn the same mistakes twice and everybody can get the benefit of the success first time round.
Yep.
Thank you.
Yeah, I absolutely agree. I mean, one of the great things of the Scan for Safety programme was the sharing that was happening between the demonstrator sites, and as this conference each year goes, the number of trusts that are here talking about what they're doing grows and grows, and it's that sharing that is absolutely going to drive the CCIOs and the CIOs. It's having the surgeon knocking on their door saying, we need to do this, and the CIOs, understanding the standards that need to happen behind that. So it's continuing that sharing, continuing that ethos.
Okay, thank you.
And my view would be that it's about the language that we use. GS1 is an acronym. It's a bit like NP Fit. This isn't about technology, it's about transformation, it's about patient safety. So if the guys from GS1 can communicate in a way that our clinicians get it, they will get it.
Yeah.
Right. Some powerful stuff there, and I know GS1 will be picking that up in various ways. So I think on that note, thank you to the panel. Thank you for those that have made presentations. Thank you, Anne, Richard, Graham, and Iain, for your excellent contributions and support for the agenda elsewhere. Thank you.
Thank you.